treatment of leukemias, and I think this is where most people are interested in. And this is just a little summary of treatment principles. And this here is mainly for fit patients. So usually what we do is to start with chemotherapy, followed by consolidation, and then there used to be maintenance treatments, but in many patients, at least 50 or 40%, they receive a stem cell transplant. The idea is eventually to get rid of, or like to decrease the tumor burden, and then to be tumor free. And here this didn't copy well, but what I want to show you is that the induction treatment 7+3, as we call it, has been around for a long time. So the first time it was described and used as a treatment for AML patients was in 1975. So this has been around for decades, and they're still doing it. This is still the standard of care. And the first clinical trial involving it was done in 1981, when we actually used the actual treatment as we do now. And the complete remission rates in younger patients below 60 years, that's how we define younger patients, is between 60 and 80%, whereas the complete remission rates in elderly patients is lower. And 7+3 means this is cytarabine for 7 days and daunorubicin and anthracycline for 3 days. That's why we call it like this. As said, this is the standard of care. We're usually giving 60 milligrams of daunorubicins on days 1 to 3, cytarabine, depending on the protocol, for 7 days. And it needs a lot of supportive care. So first of all, it's an inpatient setting. You need a central IV line. You need some tumor lysis prophylaxis. So it's very important to have a lot of hydration and also give a lot of allopurinol. And you need, because you're immunocompromised, you need a herpes simplex prophylaxis and some antifungal prophylaxis. And the period of meroplasia is approximately 21 to 25 days. And this is a period where you have neutropenia, where you have thrombocytopenia, and where you need blood transfusions to overcome this. Toxicities are, of course, as I said, you're transfusion dependent infections. So you're opening the gates for even more infections in your body. So you have to be careful when you do that. It has to be done by experienced doctors or experienced centers. Nausea, vomiting, I mean, this is supportive care for these kind of things has dramatically improved, but this is still an issue. Also, like diarrhea and mucositis. You lose your hair, and you can have severe organ toxicity, meaning like it can affect the liver, it can affect your heart and skin. And the induction mortality within the first 2 months is 5 to 10%. Late toxicities, basically, if we have an early toxicity where we damage an organ and then it carries on, it's mainly affecting your heart. Fertility is a big issue, so this should be discussed ahead of treatment. And then it can also cause like neurological, but also like in terms of it can cause depression. You're in the hospital, you feel sick, you need support. It can also cause economic issues for patients because you cannot work during this time, obviously. And then you have to have like a good social network to kind of catch you. The next thing, so cytarabine as a consolidation treatment that's what I've been doing for decades now, and there are different doses depending on age and where you locate it. Numbers of cycles are 2 to 4 cycles. Usually it's a single treatment, so there are trials where they combine cytarabine with other drugs and medications to make this a more intense treatment, but it didn't prove any advantage. And toxicities for high-dose cytarabine are conjunctivitis. So basically, you have inflammation of your eyes. You can have like some brain toxicity, which is reversible. Mucositis is typical, infections and fever, and it can also affect your liver. Just to give you, we have had these old drugs and we've been using them for decades now, but just to give you some heads up there's lots happening in the AML field, and this is a table that shows what has been FDA approved since April 2017. And you can see there are 8 new drugs that have been approved, and the last one was gilteritinib in just a year ago. And these are all drugs that are, most of them are available, and these are all drugs either for the initial treatment for newly diagnosed AML patients or most of them are in the refractory or relapse setting. And for example, midostaurin is now the standard treatment for patients with a FLT3 mutation. So also here you can see how important it is to determine the subtype. And these are all drugs that are available either through clinical trials, and I'm talking now about MBC, or through compassionate access programs. So most of them you can get, but still, as I said, these all have been FDA approved, but this doesn't mean that they are available in Canada. So this is also another reason why, and treatment has to be done, if it's in clinical trials, it has to be done in a big center. So also here logistics and play a big role to have access to these drugs. A word towards more experimental treatments, but nonetheless, I think treatments of the future that have a big potential. These are immunotherapies, and here this is the Time cover from 2016, where they published a big article about how immunotherapies work, and also they looked at the industry of it, and this was really insightful, because immunotherapies are expensive to produce, and they're of course expensive then to treat patients. So the mother of all immunotherapies is actually the allergenic stem cell transplantation, and this is something we have been doing for over 50 years now, because the first transplantation was performed in 1957. We currently do about 100 allogenic transplantations, meaning we have the donor is not the patient, it's actually somebody else. And the age limit has drastically changed. So at the beginning, they wouldn't transplant patients that are above 40 years old. And this was like decades ago. Nowadays, there's barely any limits. So we depending on the fitness of the patient, and we do transplantations in patients above 70 years, actually. So the way it works is the following. So the problem is that, and this is something that is similar for all tumors in a very simplistic way, is that tumors usually, like everybody develops cancer cells throughout their lifespan, but these cancer cells are recognized by your immune system through the immune cells, and then they're taken out of the system, they're killed off. So cancer doesn't spread and doesn't arise. However, some cancer cells are actually smart, and they mutate, and they basically put on like an invisible cloak, so they're not recognized by the immune system anymore. So they can actually arise and develop and spread in the body, and are still unrecognized by the immune system, which is kind of the police of the body. So the idea of immunotherapies is either to exchange the immune system, and thus making these cancers again vulnerable against immune cells, or to enhance the existing immune system to make them help recognize cancer cells again. And allogenic stem cell transplantation is a way where we try to exchange the immune system. So it's a combination of giving chemotherapy and giving a new bone marrow. And this bone marrow will produce immune cells, and these immune cells then kill off leukemic cells. And this is and we call this a graft versus leukemia effect. So basically, if you're the patient, you receive chemotherapy and radiation to get rid of your existing immune system and existing leukemic cells. And then there's a donor who gives either bone marrow or peripheral blood mobilized stem cells that are infused into the patient. And then there's like this thing we want to prevent is called graft versus host disease, because unfortunately, these new immune cells, they are not only attacking cancer cells, which they should, but they can also attack normal cells. And this can cause a lot of severe side effects. And this can be so extreme that you're actually cured of your leukemia, but then you have major problems or can even die from the side effects of this treatment. So that's why this has to be done at really experienced centers and cannot be done by any doctor or a hospital. So what are the things we want to balance and what are we to work on in allogeneic stem cell transplantations? So this is, first of all, we want to have a low risk of relapse. So we don't want the disease to come back, but we also want to have like a low toxicity. And this is what we have to balance. Toxicity is determined by comorbidities, performance, and donor characteristics. And risk of relapse is determined by the subtype of leukemia and age in response to treatment. So these are the things we have to look at, and that's what we always discuss in our patient rounds when we say, okay, how do we treat and how do we transplant this patient. And you can see that the outcomes are actually not too bad. So this is from the US side. This is statistics showing that if you catch an AML early and you're at an early stage creating a good tumor clearance, then the outcome is pretty good. So 5-year survival rates are around 60%. But if you have advanced disease and transplant somebody, and this is just an example for somebody who has maybe a brother or a sister, and then they use these siblings, and these siblings might match as donor, advanced disease, the outcome is much worse. So it also depends on which stage of your disease you are. If you're in your first complete remission, this is much better than having like a late complete remission where the disease has already evolved throughout the treatments. The other question we always get is like CAR T cells. What about CAR T cells in acute myeloid leukemia? And you can see that, and the way CAR T cells work is basically you take your own immune cells, in this case T cells, you manipulate these T cells when you extract them from the body to make them recognize again leukemic cells. Then you expand them and then you reinfuse them to the patients. So here you don't have this graft versus host disease, but you're relying that these CAR T cells are modified. They're like kind of like fighting dogs that have been made really like aggressive, and they're given back to a patient that these kind of sniff out leukemic cells and kill them off in your body. And what's really good about it, it's a tailored treatment. It's highly effective. It has some side effects, but we are able to manage them better and better. But it's a very expensive treatment, and it's only limited. Availability is very limited for patients right now. So most of the CAR T cells treatments arose from